Good afternoon, everyone, and welcome to the second annual University of Michigan Injury Prevention Center Research Symposium, abstract session on violence and ACES, adverse childhood experiences. My name is Dr. Justin Heinze, and I'm an assistant professor at the University of Michigan School of Public Health. I will be moderating this session. Thanks for joining us. We are very glad to have you here. As a reminder, this session is being recorded. Only the presenters and the moderator will be visible. Our chat function is disabled, so please use the Q&A feature for all questions. If you have a question for one of our presenters, please ask by typing it in the Q&A feature in your bottom menu bar at any time. And please indicate who your question is for by including their name at the beginning of your question. Q&A will take place after all the abstracts have been presented, but we encourage you to send in questions throughout the session so we can have a chance to review them. We will answer as many as time allows. Our presenters will have 5 minutes to present their abstract. We will share their slides while they are presenting. All abstracts can be found on the center's Symposium webpage. There are 3 other abstract sessions occurring at this time, and as much as we would like you to stay in this session and listen to these great presentations, feel free to visit other sessions. Recordings of all sessions will be released in the coming weeks. Now, join me in welcoming our abstract presenters. I will introduce everyone now so that there's no interruption in the flow of the presentations. So please welcome Dr. Amber Hill from the Department of Pediatrics, C.S. Motts Children's Hospital and Michigan Medicine, Elise Tulin from the Department of Health Education or Health Behavior and Health Education, University of Michigan School of Public Health, Dr. Hunit Kaur from Johns Hopkins International Injury Research Institute at the Bloomberg School of Public Health, Hurley Riley from the Department of Health Behavior and Health Education, University of Michigan School of Public Health, Dr. Laura Seawald from the University of Michigan Injury Prevention Center and Department of Emergency Medicine at the University of Michigan Medical School, and Dr. Vijay Singh from the Department of Emergency Medicine, Family Medicine, and Internal Medicine Medical School at the University of Michigan. Presenters, when it is your turn to present, please turn on your audio and video and then turn them off after you're done. Okay, we will begin sharing the presentations now and get started.
Hi, everyone. Are you able to hear me okay? My name is Amber Hill, and I am a pediatrics intern at Mott Children's Hospital here at the University of Michigan. And today I'll be presenting some of the work that I did during my MD PhD at the University of Pittsburgh with Dr. Liz Miller. This study is entitled The Longitudinal Assessment of Sexual Violence and Its Associations with Drinking Among College Students. Next slide, please. We all know that sexual violence is an epidemic in this country, and it is unfortunately very common on college campuses, with over a quarter of female and almost 7% of male undergraduate college students experiencing sexual violence during college. And this statistic doesn't include those who experienced sexual violence prior to college. We also know that sexual violence and alcohol use are inextricably linked, with 50 to 70% of sexual violence on college campuses involving alcohol in some form. And this negatively impacts the survivor's decision to seek help. After doing a thorough literature review, we found that there were several contradictory studies that investigated this bidirectional association between alcohol use and sexual violence. To provide some clarity on these associations, we decided to use complex statistical methodologies, including path analyses and structural equation models that allow us to map multiple associations simultaneously and look at associations over time. And we did this to look specifically at sexual violence victimization. And I just want to be clear that I'm not talking about perpetration, just victimization here, and how that is associated with alcohol use, and then more specifically, binge drinking over time. We did this using a sample of over 1,500 college students seeking care at campus health centers across 28 campuses in West Virginia and Pennsylvania. Next slide, please. What you can see here is a simplified version of our results. So you see sexual violence victimization as a latent construct on the top row, and this was measured at 3 time points. So in the yellow, we have our baseline data. So we looked at sexual violence victimization before and during college. And then you can see in the blue, we have sexual violence victimization in the past 4 months at time 2 or 4 months follow-up. And then in the orange, you can see sexual violence victimization in the past 4 months at T3 or 1 year follow-up. Similarly, we measured alcohol use in the past month at these 3 time points as well. And then you can see the associations or the beta regression coefficients between each of these variables. Those that are bolded with a solid line are those that were statistically significant, and those that were not bolded with a dotted line are those that are not statistically significant. When first looking at the autoregressive results, or the regression, sorry, so that's how sexual violence victimization in the past predicts sexual violence victimization in the future, or how alcohol use in the past predicts alcohol use in the future. All of those associations are statistically significant, which is consistent with prior literature. And then one of the other things we were really interested in is looking at the cross-ligand effects. So how does sexual violence in the past predict alcohol use in the future? And how does alcohol use in the past predict sexual violence in the future? And this is controlling for all past experiences and behaviors. Next, please. So what our results showed for this specific study, looking at college students seeking care at campus health centers, was that sexual violence victimization was predictive of alcohol use, but the alcohol use was not predictive of sexual violence victimization. Next, please. Similarly, we looked at how sexual violence victimization was related with binge drinking, and that was defined as 2 or 3 or 4 or more drinks for females within a 2-hour period, and 5 or more drinks for males within the same time period. Next, please. And we saw similar results in that sexual violence victimization was predictive of binge drinking, but not the other way around. Next, please. So in conclusion, within our study of college students seeking care at campus health centers, our findings were supportive of the self-medication hypothesis, or that individuals who have experienced sexual violence may be using alcohol use or binge drinking as a coping mechanism for their trauma. But our findings call into question the risk reduction perception theories in that alcohol use may not be predisposing individuals to become sexual violence victims. I think we are starting to see from the literature that prevention efforts, violence prevention efforts that are moving beyond targeting binge drinking in isolation and instead investigating sociocultural norms associated with college drinking are proving to be effective. We as clinicians should be attuned to how patients' drinking patterns may be influenced by their prior traumatic experiences, and there is an urgent need for improved integration of sexual violence and substance use services to better support survivors. Thank you so much for your time.
Hello, everyone. Welcome again. Today I'm going to be talking to you a little bit about electronic teen dating violence, the prevalence by age, and the association with forms of cyberbullying, victimization, and perpetration, depending on the social relationship, using a representative sample. This work is in collaboration with Justin Heinze and was funded in part by a Summer Writing Award. Next slide, please. So the research questions we really wanted to address in this piece was what the national prevalence of electronic dating violence was by age, as well as how it overlaps with other forms of cyber aggression and cyber violence. So to answer these questions, we used the National Survey of Teen Relationships and Intimate Violence, which is also called STRIVE. STRIVE is a study that was a prospective longitudinal study collected over 4 years between 2013 and 2017. And it provides a representative sample of adolescents aged 10 through 18 for a total number of 2,354 adolescents. The measures we were looking at were electronic teen dating violence, as well as electronic abuse, with social relationships relative to friendship, peer acquaintances, so same age peers, strangers who were the same age as the youth, and then known and unknown adults. And to evaluate this, we used weighted bivariate and multivariate logistic regression. Next slide, please. So we looked at victimization and perpetration separately, and what we found is that 2 in 5 youth reported electronic dating violence victimization in the past year. So it's not lifetime exposure, but rather in the prior year. That next graph, the blue line, is the prevalence by age. So you can see that prevalence between ages 10 and 15 increases pretty sharply, and then there seems to be some matter of leveling out of risk but still a very high prevalence. And again, this is of the past year, so it's not lifetime, but rather in the prior year. The third part of the figure shows what relationships were significantly associated with electronic dating violence victimization. So we can see that a friend that is cyberbullying the youth online is associated with electronic dating violence victimization, as is electronic teen dating violence perpetration, so the youth perpetrating intimate partner violence online. Peer cyberbullying, so a peer who is not a friend but is the same age and known to the youth, cyberbullying the youth, as well as an adult cyberbullying the youth. So we are seeing kind of a clustering of victimization in that first gray box. In the second part of the box, looking at perpetration, we see that 1 in 5 youth report electronic dating violence perpetration in the prior year. So a little bit lower than the 2 in 5 reporting victimization, which may be reflective of report bias, which is we've seen in other work, both in terms of electronic dating violence as well as in-person dating violence. Again, we have the figure that depicts prevalence over age. So ages 10 through 18, we again see a sharp increase between ages 10 and 15 roughly before a little bit of a decrease, it looks like. But again, this is in the last year, so there's still quite a bit of perpetration happening even at ages 17 and 18. And then the two relationships that we saw that were associated with electronic dating violence perpetration was electronic teen dating violence victimization, which isn't surprising given the prior set of findings. And then finding that the participant was cyberbullying an adult. So in this set of regression models, we found kind of a clustering of the perpetration piece. Next slide, please. So to summarize, electronic dating violence is very, very prevalent. It's prevalent across time, across ages, but there is a peak at around age 16. We see that perpetration and victimization often co-occur. And then within victimization, youth seem to be exposed to multiple forms of victimization, such as being cyberbullied by a peer. And then adult cyberbullying is associated with both electronic dating violence, victimization, and perpetration. And I'll hand it off to the next person. Thanks so much.
Hi again, everyone. My name is Hunit Kaur, and I'm going to present me and my co-author's work on a scoping review on the effectiveness of interventions for adolescent intentional injuries in India. This work was originally part of a larger project, which is the AVID project, funded by the Botnar Foundation from Switzerland. The objective of this scoping review is really to identify existing intervention in India's for the prevention of adolescent intentional injury. And by intentional injury, for this specific work, we are really focusing on suicide and self-harm. Next slide, please. The methods we did a systematic search on databases on April 6, 2020. Search strategy was a systematic search strategy was using key terms for adolescents aged 10 to 19 years old, and interventions to prevent self-harm and suicide. We put in a time frame of 2009 to 2020. Double screening approach was in place throughout the process, from abstract screening all the way through data extraction, with discrepancies resolved by a senior study team member. We also assess for study rigor and risk of bias using various tools according to the study design. For RCTs, we use the Cochrane ROB. For non-RCT quantitative studies, we use the Evidence Project tool. And for qualitative study, we use the CASE-AP qualitative checklist. For the overall review and reporting, we are following along the PRISMA guidelines for scoping reviews. Next slide, please. So this is actually a part of a larger series of reviews that we did to support the AVID project. The initial search resulted in around a little over 4,000 citation hits from 4 databases. And that all came down to 145 total articles for the larger review. For this specific review report, we're including 12 articles for our synthesis. From those 12 studies that were included for this review, 2 overarching intervention themes were identified. The first one is educational intervention, and the second one is psychotherapeutic interventions. Both have 6 different studies included. For the educational interventions, there are various tools that people have used for the interventions. One is community peer education, and then there's teacher training to address risk factors and integrate life skills, school activities to address school climate for bullying within schools, and in-school activities addressing skills such as problem solving and positive thinking. On the educational intervention, mostly all school-based. The second theme that we found on the literatures are the psychotherapeutic interventions. These are mostly clinical based, so they are delivered by trained psychiatrists and trained psychologists. Mostly are community behavioral methods, cognitive behavioral methods, transactional analysis, and mindfulness sessions. Next slide, please. So from 12 studies, 11 showed positive results. So overall, the intervention showed promising results to prevent intentional injuries, although short duration of these interventions across the study significantly limits the translation to real work practice. Also, lack of long-term effectiveness evaluation is also prevalent. Subsequent research needs to delve deeper into the various factors and improving data that will promote long-term evidence-based intervention and guide continuous assessment. So sustainability is one issue. The short life of this intervention is also an issue. And that concludes my presentation. Over to the next presenter. Thank you.
Hello, everyone. My name is Hurley Riley. I'm from the University of Michigan School of Public Health. And today I'll be presenting on a project called TIPS, which I serve as the project coordinator for. So as many of you may already know, trauma and adverse childhood experiences, or ACEs, are common forms of injury, and they can negatively affect child health and child development. So in fact, the CDC reports that nearly 2/3 of adults have experienced at least one ACE. And with the COVID pandemic, this has really exacerbated the likelihood that children will experience adverse childhood experiences and trauma. So from issues ranging to homelessness, to food insecurity, to even loss of a caregiver. So this project is very timely. And trauma-informed school environments can promote resilience and really help children heal from these adverse experiences. So we proposed a novel system-oriented framework, trauma-informed programs and practices for schools, abbreviated as TIPS, to help schools and school professionals establish school environments that promote resilience and positive coping among children. Next slide, please. Yeah, so the TIPS framework, it's based around these 10 core pillars of a systems change process. So these 10 core pillars focus on areas such as like building community in the school, incorporating like social, emotional skills into the academic environment, reducing punitive discipline. So, 10 different areas so we can make the schools more trauma informed. So the TIPS framework, it uses a collaborative multi-stakeholder approach to ensure the uptake and sustainability of these strategies in schools across the state. So basically what this means is we work with different local and state educational organizations and agencies to disseminate TIPS. So for example, we've worked with like the Michigan School Health Coordinators Association to disseminate tips in some of their trainings. And we've developed research-based program and implementation guides in consultation with our different, partners and our different stakeholders. So currently we're doing feasibility and usability testing of the TIPS framework. So we're holding informational interviews with different school professionals, so teachers and different administration, school administration across the state. And we've also been conducting TIPS trainings and workshops with various schools and school districts across the state of Michigan. Next slide, please. So yeah, this work is still ongoing, so we don't have much data to present yet. Right now, we're developing some assessment tools so we can see, participants who they can do this assessment like before and after the trainings just to see if we're helping develop their knowledge. So right now, we've been continuously refining the TIPS content and the TIPS materials based on these informational interviews. So these slides say 7 interviews, but we're actually up to 10 interviews now. And then we've also been using a lot of feedback we've been getting from our different schools, our different partners and stakeholders to help refine this content because we want it, to be easily digestible. And we've also been presenting the TIPS framework through these professional development trainings that I've mentioned. And the slides say 8, we're actually up to 9 trainings that we've held with different school districts across the state. And we've also have like these free materials, so program implementation guides, and we've also developed animated videos just giving an overview of the TIPS framework and those 10 core pillars. So ultimately, we anticipate the implementation and the sustained use of the TIPS framework in schools will reduce trauma symptoms among students. Hopefully the TIPS framework will improve school professionals' knowledge of trauma. And ultimately, we just hope the TIPS framework can just support a positive school climate. So at the bottom, I gave some examples of these 10 core pillars. So these are just 3 examples, like tip 4, build community in the school, tip 6, reduce punitive discipline, and tip 9, incorporate social emotional skills and positive coping. So, if schools use these broad 10 core pillars, we hope they can be more trauma informed. Next slide, please. Yeah, so conclusions, TIPS is a low-cost alternative to individualized models of care. So TIPS may mitigate the negative impacts of, adverse childhood experiences and can promote the well-being among all children versus focusing on specific individuals. So TIPS has a potential for broad and sustained impacts for an entire school community. And the framework is very generalizable. So as you can see, those pillars were very broad, so they can be easily tailored to the local context. So any school can use these and that can facilitate access and fit. So if you're interested in learning more about TIPS, please feel free to reach out, or you can visit our website at tips.health. And thank you so much for your time.
Hi, everyone. So again, my name is Laura Seawald, and I'm an emergency medicine physician and postdoc fellow with the IPC. And today I'm going to talk to you about an adaptive intervention for alcohol use and violence among adolescents and emerging adults in the emergency department. Next slide, please. So just as background, so this study actually builds off of previous work with one of our projects called Safer Teens, which found that a brief intervention in the emergency department that was conducted among youth screening positive for aggression and alcohol use was effective at reducing severe peer violence and alcohol consequences. However, when looking at that data further, we found that those who did not respond to the brief intervention were also more likely to report more depression and delinquent behaviors, likely representing a higher risk population. So with this in mind, we wanted to examine if a more tailored approach would be effective at reducing violent behavior and alcohol misuse, not only for these non-responders, but also for responders as well. So to examine this question, we implemented an ongoing sequential multiple assessment randomized trial, or SMART study. We're conducting the study with youth ages 14 to 20 in an urban ED who report binge drinking and aggression within the past 4 months. So after receiving a brief intervention in the emergency department, our participants are then randomized into either receiving 4 weeks of a remote health coach session or 4 weeks of text messages. Then after week 4, the participants are re-randomized based on their response to either one, continuing with that condition, or being ramped up if they're a non-responder, or ramped down if they're a responder. And in this case, a non-responder is someone who reports any binge drinking or aggression after receiving their first 4 weeks of their intervention. So looking at our flow chart here, that top box shows who was screened positive in the emergency department for binge drinking and aggression, and then received their behavioral intervention in the emergency department. Then again, they're randomized into either getting 4 weeks of health coach sessions or text messaging. And if you follow the health coach arm down, you'll find that you'll see our 1 month responders and 1 month non-responders. Looking down the 1 month responder pathway, again, they're re-randomized at this point, and they will either continue on with 4 additional weeks of health coach sessions, or in this case, they would be ramped down into just an enhanced usual care group. For our 1 month non-responders, again, they will continue on into the original condition, or in this case, they would be ramped up with a continued 4 weeks of their health coach sessions, but they would also then start to receive daily text messages. Looking at the text messaging arm, again, you'll have your 1 month responders and 1 month non-responders. For 1 month responders, similar to our health coach session group, they'll either continue on with their condition or be ramped down into the enhanced usual care group. And then for our 1 month non-responders, they will continue on, or in this case, be ramped up into receiving 4 weeks of health coach sessions. And everyone will get a 4 month and 8 month follow-up. Next slide, please. So looking at our results, so far we've had 320 participants enrolled. Our goal is to get to about 700. The average age is 18, 21% are male, 45% are African American, and 55% receive public assistance. Looking at risk and protective factors, our participants report drinking an average of 8 alcoholic beverages weekly. 83% report alcohol use. About 12% report past 4 month firearm carriage. Almost 50% of our participants report either, or they report both depression and anxiety symptoms. They're screened positive for depression and anxiety, I should say. And then looking at whether they feel supported or expected things to happen to them, our participants don't really think that those things would, that they have those support systems. For acceptability, 78% report that they like the health coach sessions, and 71% report they like the text messaging. Some things that they particularly highlight with the health coach sessions are they enjoy talking about coping mechanisms, fun activities, positive support, and community connections. And so far, we've had an 80% weekly survey completion rate. Next slide, please. So far, our initial findings support the acceptability of an mHealth intervention for at-risk youth involved with binge drinking and violence. And our future papers will examine the efficacy of an adaptive mHealth intervention with either dose increased or decreased based on response from the SMART study. And with that, thank you for your time.
Hello. I'm Vijay Singh, family medicine physician with appointments in emergency medicine as well. I work with colleagues at the American Academy of Family Physicians, Corey Lutkin, Dr. Beth Callan, on a project around family medicine-based provider and staff, identification and response to male patients who perpetrate intimate partner violence. So rather than looking at victimization, looking at perpetration, focusing on male patients and thinking about the outpatient setting and what can providers do, what they think about this topic. So as background, as we've seen in a lot of other presentations, relatively high prevalence, 1 in 5 men in the US report perpetrating physical violence against a partner. 2 in 3 of these perpetrators, seek routine healthcare services. So these are patients who are seen in healthcare. 9 in 10 men in the US report being identified, receiving questions about if they perpetrate violence. violence. There are various screening tools that exist to identify perpetrations, been used in research settings and healthcare environments. There's a 3-question perp screen, the 5-question hits screen, similar to victimization, just asking about perpetration. There are counseling programs. Dr. Sewell just talked about the Safer Teens program. Has been used in research settings, maybe eventually with more translation could be used in actively in clinical settings. There are counseling programs through the criminal justice system called battery intervention programs that exist for men to potentially seek care through. Those programs have not been tested for patients, men referred from primary care or other healthcare settings. And despite, there being screening tools, some intervention programs, even ones that exist in local community settings, physicians feel unprepared to ask patients about perpetration of violence. They don't have knowledge of this topic. They don't have the training. And so part of this study that I conducted with funding from the American Academy of Family Physicians was to understand family medicine provider and staff identification and response to partner violence perpetration. Next slide. So for methods, it's still ongoing. I've conducted individual, online, audio recorded interviews, been transcribed verbatim. It was exempt through our University of Michigan IRB. I have 3 team members, so myself plus a qualitative analyst, data scientist, again, these colleagues in the American Academy. Family physicians, we use qualitative content analysis to develop codes and themes. I have recruited providers as staff from 2 University of Michigan academic family medicine outpatient centers. Starting from last year, December 2020. My interview guide addresses first, experiences providers had with speaking to male patients about perpetrating violence, and then kind of the nuts and bolts about how would screening happen, like what's the workflow, like what would it look like, what needs to happen. So how would questions be delivered electronically, in person, over the phone, types of visits, where it would happen, routine health maintenance exams, other types of exams, who would review screening results if it's a positive screen, how would a referral happen, to which services make sense, an intervention if it was to happen on site, the location of it, even, is it remote, how is it delivered, and then just in general organization challenges, kind of barriers, facilitators, and what resources are necessary for a healthcare team to really think about how to implement this program. So next slide. So for my results, just even an update from last month. So I have 6 providers currently, 3 physicians, 1 is a medical director, 1 clinical psychologist, 1 medical assistant, 1 social worker. I have 3 more interviews scheduled the next few days, actually, 2 more social workers, a nurse. I hope to get to a 10th provider as well. So it was a purposeful sample trying to get providers of different training backgrounds who have different roles in a healthcare setting, and just to understand what their experiences are like. So as you might imagine, providers have few experiences talking to men about partner violence, despite some routine screening that might happen, even about victimization. It's partly related to probably disclosures that men may have. Providers did talk about talking to male patients about perpetrating violence, say, against someone in the community, and learning about perpetration of partner violence from a patient when that patient wasn't their direct patient. Like there was someone else in the primary care group, like a female patient, where they learned that this other person perpetrated violence. So this kind of indirect awareness of knowledge, but not directly interacting with that male patient then about the violence. So a number of staff members and providers talked about how these identification can happen through an electronic means, through the patient portal, and providers could also ask in-person questions. Providers, describe various barriers, patient focus, like trust and comfort, facilitators, like the electronic medical record, patient portal use. Providers did describe ways to increase use of interventions by patients, like through warm referrals, using virtual visits, having patients feel comfortable wherever they are in the world to receive some of these interventions. And then organizational challenges typical for partner violence victimization screening, time and resources. Next slide. So in conclusion, providers and staff describe various methods to identify and respond to malpatient perpetration, including use of a team approach, multiple providers in one team, a warm referral to, say, social work, recognizing barriers and building on the continuity relationship that exists in primary care. And finally, critical to implementing will probably be using workflows that already exist, like in victimization screening. Thank you.
Thank you all for this informative session. We have some time for questions from our audience. And so I'm going to ask the presenters to please turn your cameras back on. For those of you who have been watching and would like to ask a question, you can use the Q&A box at the bottom of your screen. I'm actually going to start with a cross-cutting question for all of our panelists, see if that generates some conversation, and maybe we'll also hear from some of the audience in terms of your questions. But I am probably betraying some of my own research bias here. But one of the things that jumps right out to me as I listen to these presentations is that there are methodological innovations across each. I saw smart trials and implementation science, scoping review, structural equation models. So I'm gonna ask each of you to reflect on the innovation of your methods, whether that's the approach you took to answer the question or the analysis that you use. I mean, you can think about it fairly broadly, but why are the methods you are employing important to the understanding of violence in ACEs? And if it's okay, I'd like to start with Vijay and then just go in reverse presentation order. So again, thinking about why those innovative methods are important right now.
Yeah, no, thank you for your question. It addresses different ways to answer a question, different ways to maybe eventually implement programs in clinical services, social services. And, particularly in my area, it's like this project is part of a broader project to adapt safer teens that, Dr. Seawald's talked about to, older patients, primary care, adults, and then really, implementation science is talking about what are the barriers and facilitators to providers to try to roll out evidence-based medicine programs that have been used in innovative ways, but then how do you actualize it? So I think that's what my work is trying to get at.
All right, implementing a SMART trial. Why is that important right now for understanding violence in ACEs?
Yeah, so I think, the thing about a SMART trial is that it really asks kind of two questions. So the first one is, does one particular intervention work better than the other? So in our case, does text messaging work better than health coach sessions? And so then once you kind of take a look at those, the other question that you're asking is, what kind of dosing does a particular person need for an intervention to be effective? So when you think about it kind of clinically, starting like someone on a new medication, like a blood pressure medication, you give them this medication, and then does that person need to be titrated up or down? How do you want to use so it kind of helps to speak to how you want to use your resources, or do they need a different medication entirely? So it really helps to address the heterogeneity of what our participants need.
Thank you. Hurley, you're talking about a model moving away from individualized to more of a systems approach. Why is that important?
Yeah, I think using this like more systems approach. So typically when we think of like trauma in schools, we might think of like these individualized approaches, focusing on certain students who might need these resources the most. But I think using this systems change approach is good because, you can help all students. So you can even help the staff as well and build community within the whole school. You can, teach social, emotional skills to everyone. So I think these are really important things because it helps build resilience. So, even those who haven't experienced these adverse childhood experiences, I think it can still benefit them.
Hunit, a scoping review is a very specific approach to trying to collect a lot of information across studies. Why use that?
So this scoping review itself was done to support a larger project, which is that we're using an artificial intelligence to identify risk factors and predictors of suicide and self-harm. So the background of the method itself is that there's a massive underreporting, massive underestimation of the true prevalence and incidence of suicide and self-harm. especially in LMICs in India specifically for this project. And we're looking at artificial intelligence really to dig deeper of data that is untapped data for us to figure out more what's buried underneath to expose those data.
Excellent, thank you. Elise, it's a national represented sample. It's an age interaction. Why use this approach? Why is it important?
Yeah, thanks. So we have quite a few cohort studies looking at intimate partner violence, dating violence, and specifically electronic dating violence, but we don't have a ton of nationally representative studies showing prevalence rates. And taking the developmental approach is really important given the number of changes that happen in adolescence. So in early adolescence, youth are generally more reliant on parents and systems in place for transportation. Around age 16, we see this big kind of shift within both cultural as well as social interactions where youth can start to drive or at minimum, are in a position where they can get a driver's license, which is a big step in autonomy. And then at age 18, of course, you are in, quote unquote, a legal adult. You can be, you can vote, you can go to war, et cetera, et cetera. So I think that looking at these different risk factors across adolescence is really important, and really teasing apart the age interaction is critical. We didn't actually do an age interaction within the, we didn't test the age interaction, but the prevalence rates are pretty clear across now multiple studies we've done, and that it's a nationally representative study is really helpful in terms of generalizability.
Great, thank you. And Amber, a cross-lag panel model, there are easier ways to look at data. Why that way?
Yes, there are easier ways. I think one of the things that after kind of reviewing the literature, and we've been working on a systematic review as well at kind of looking at the association between adolescent relationship abuse and all different forms of substances. And one of the things that really came out of that, and just came out of like our literature reviews that we were doing, is that there are a lot of studies that show contradictory results. And I think all of us can agree that there needs to be there needs to be more integrated interventions to help individuals who are experiencing both relationship abuse as well as substance use. And so one of the things that we wanted to do was how can we kind of provide clarity for this? And so we kind of had the question first, and then we found the methodology that would help us answer the question, where we could model longitudinal relationships. We can model relationships that were happening at the same time. And then one of the other things with structural cohesion modeling is that you can control for and help minimize measurement error. So all of the, we measured sexual violence with a 6-item scale. And so we can actually help improve the accuracy of our measurement by using this form of data. So it was kind of one way that we thought would provide a little bit of clarity. I mean, obviously there are limitations to our sample and limitations to all methodologies, but I thought it was kind of a really unique way to approach this question.
Great, thank you. Different questions, different approaches. It's fantastic to see a variety and diversity in methods. So we have a couple questions in the chat that are kind of focused on the intervention aspect and in public health. And I've learned in emergency medicine in the medical school too, we're trained to ask, where's the intervention? So some are explicitly testing interventions, whereas others mentioned your findings can inform interventions or screening tools. So again, thinking about violence and ACEs, I think the question sort of in the chat is, what are some of the primary barriers and opportunities for intervening in these spaces, as well as how can we expand some of these promising interventions? So this question was directed at Laura, so we'll start with you, but then I think there are others, if you have some ideas too, we can go there.
Sure, I'll start off. So I think part of the first question the question that's being asked right now is sort of related to the Safer Teens project, which is that we understand that these brief interventions work. And so how to expand that intervention a little more broadly into the community. And so we just actually got funding to do just that. And so we're going to be actually implementing Safer Teens into 3 different sites in Western Michigan, an emergency department, a primary care office, and then a community site. And so that's sort of how we're actually going to be implementing Safer Teens a little more broadly, this brief intervention that we know works. But then kind of supplementing that, again, in our Safer Teen study, we recognized that there was a group of people we weren't quite reaching. And I think that the study I spoke about today is really trying to get at how do we improve upon this to have, again, to reduce violent behaviors and alcohol use in this population among a population that we're also sort of missing. So, our number needed to treat, I think, for um, violence reduction was like, 8. So that means not bad, but that also means that you're missing 7 people. So how do you kind of expand that number? And I think that's what the study I spoke about today is trying to get at. But also we do recognize that we want to more broadly implement our study, and that's what we're going to be working on next.
Okay, thank you. And Hunit, I believe you covered at least several interventions through your scoping review. How can we make that translation into practice? How do we take some of the preliminary efficacy that you might have found in that review and move that forward to a real life intervention?
I think what's really important is making the intervention to be as context specific and cultural specific as to our target population. That is number one. And second is really keeping sustainability always in our mind when we are going to implement. Because a lot of interventions, especially again in low and middle income countries, it's short lived and it's not as sustainable. That also ties with donor funding and all those programs in LMIC, as everybody probably have been familiar with. But yeah, I think those are the 2 most important factors: being cultural specific, context specific, and sustainable.
Wonderful. And Hurley and Vijay, I believe I heard each of you mention implementation science within your presentation. Where is the opportunity with implementation science in a framework in terms of implementing and also expanding? Hurley, I don't know if you might have a comment.
Yeah, well, I think there's a lot of groups doing like trauma work within schools, especially like given the COVID pandemic. So one thing we're trying to do to expand our reach is to partner with a lot of or well, not with a lot, but with organizations who are doing similar work versus like reinventing the wheel. And also like teachers just have a lot on their plates. So trying to like incorporate this into like existing like school district trainings versus trying to do like this completely separate program, just trying to incorporate it into like existing trainings.
Okay.
Yeah, I could add, I mean, so I think, if you were thinking of a clinical program specifically, rather than maybe in a public health site or some other social service site, I mean, using a workflow that already exists, like it's pretty standard in most health centers that there is a protocol to identify if a woman, an adult generally, has experienced in-partner violence. Like that exists somewhere. People have had some training on it. And building on that workflow to identification questions, some type of intervention. The intervention could be in the community. It could be healthcare center based. Who are the different team members who take the different parts, and really thinking about that to show that the barriers that all providers will talk about are time and training. And there's the training is a piece that there needs to be a clinical champion to like tell, like, here's an evidence-based program, here's what we do. But then each provider still will feel like, I don't have time to do that. I already have to do too much other stuff. There's too many other things to do. And hey, I never got trained well in the first place. So not only implementing training, but thinking about it's not that different. Like a lot of providers would talk about depression screening like the suicidal question, and thinking about how does that deal with violence if we're thinking of suicidal ideation, homicidal ideation. It's just trying to use workflow that already exists, I think, and a team approach to it.
Thank you. I'm going to shift gears a little bit, and Amber, you gave me the perfect intro or entree. The problem of measurements, and I think especially the lack of consistency across studies focused on violence and even ACEs, I think it vexes me. It vexes a lot of the work, but I think it's a conundrum because I'm not sure we can use the same tools to assess sexual violence as we can violent interventions online or physical aggression during an emergency apartment visit. So what are some of the ways that we can assess violence in its many forms? And should we be pushing for consistency across studies, or are violence and ACEs, are they just too varied for uniform assessment?
Yeah, I think that's a great question. And I think that I've spent a lot of time thinking about different measurements and did a lot of my PhD work on different psychometrics, looking more specifically at gender equitable attitudes. How do we even measure that? And I think there's just a constant struggle between how do we make something generalizable, but then how do we also make it appropriate for the interventions that for the interventions and the populations that we're working with. And I think that's the struggle. So I think one of the things that we can do to help it is when we're developing measures, we're keeping in mind, the populations in which we're developing them. So a lot of times measures are developed within very narrow populations and then are expanded and just kind of accepted and then used across all different cultures, races, ethnicities, age groups, without necessarily being adapted. And I think we need to be mindful about that. And part of the work that I did in my project, which I didn't get into, was doing kind of a psychometric analysis. So doing like a factor analysis on the measurement of sexual violence, those 6 items in our specific population. And obviously that's not something that we can do every single time, but I think I've been trying to be more mindful of that within the studies that I'm working. Do a lot of work with reproductive coercion. How are we measuring that within this specific population, and just kind of checking in and making sure we're being mindful of measurement is critical. So appreciate you bringing that up.
Thank you for that response. And Elise, I know that you are a measurement scientist. I believe you've given this some thought in the past, the challenges of trying to measure across different forms of violence. You're doing a lot of work online, speaking to trying to measure violence that happens online versus in person. Would you care to comment?
Yeah, I mean, Amber, those are all great thoughts, and I think they're spot on the money. And it is a challenge between wanting to be generalizable but also specific. I think one big problem we see is that some of the measures we use are incredibly old, or we're built off of very homogeneous populations, and so reevaluating what those definitions are, how we're measuring them among different populations and at different time frames is really important. I do a lot of electronic dating violence work. No one had cell phones in 1990. The very, very, very top executives had brick phones, but like no one had a smartphone. They weren't, they didn't exist yet. And now they're ubiquitous in not only adult life, but also adolescent life. And so, kind of staying on top of things, as humans develop and as our lives change, is a big part of the measurement problem, because you do want to be consistent across time, epidemiologically, to be able to compare are things getting better or are they getting worse? But you also have to be sensitive to the fact that things are changing. So I don't think that's really an answer. It's just more of random thoughts.
Nothing wrong with that. And Hunit, I'd be curious if you can also, so most of the work was focused on India and whether or not the measures that might have been developed elsewhere are translating to that population.
Yeah. So far, we're still using internationally recognized tools. We tried to look at country-specific tools and that are used in India and Vietnam, but mostly clinicians still use internationally recognized tools over there. So.
And Laura, I guess by nature, a SMART trial is designed to be adaptive. It's designed. The measurement doesn't necessarily have to change, but are there those instrumentation threats to internal validity that you have to worry about?
I think most certainly, and a lot of right now we kind of to the point of we're just starting to really start to use like mHealth and those things. And so these measures aren't even really that developed yet. And so I think part of it is in this process right now, we're starting to kind of even define our own measures and seeing what these look like. I think everyone is very cognizant about looking broadly at the literature and seeing what makes the most sense and establishing your measures in theory and good, clinical practice and things like that. But I still kind of, to speak to everyone else's point, is, it's hard right now to even know what our measures are because we're using a whole new modality of delivering these interventions in some case. And so I think it's just more of a place to be explored, and more data is needed to kind of help us direct what our measures should be and how generalizable they can be.
Thank you. We have another question in the chat. It's directed towards Hurley, but I'm going to ask everyone to speak to it, I think, because it's addressing the elephant in the room. But here's the question. Hurley, what challenges have you experienced building community within schools during COVID-19? That's that overarching thing that I think we're all going to have to worry about. But does TIPS address the trauma and adversity that students have faced specific to the pandemic?
Mhm. Yeah, so to answer the first part of the question, so that's kind of like beyond the scope of my work on the project. So I don't work directly with the schools. But right now we're working on these assessment tools and these informational interviews we're asking, school professionals like, what challenges do you expect to experience when implementing these, or what challenges did you experience when you were trying to implement each of these pillars? So within like these next couple of months, hopefully we'll have good data about like what challenges schools are experiencing towards implementing each of these pillars. And to answer the second part of the question, does TIPS address the trauma and adversity that students have faced specific to the pandemic? So yeah, we've actually been trying to adapt our materials to be more COVID specific. So for example, I'm thinking of like our newsletters that we send out every other month. So at the start of the school, we kind of adapted these to focus on COVID. So our first newsletter in September was like returning to school after COVID-19, and we kind of just gave like resources. And then our second newsletter was like building community in times of uncertainty. So we kind of, talked more about just how to build community after this, this long hiatus from schools.
Thank you, Hurley. And Vijay, COVID-19 and intimate partner violence. I get asked in the school safety realm, do we see increases? Are new concerns introduced? Could you speak to that a little bit from some of the data that you might have?
Yeah, I mean, for this project, like I didn't specifically look at like increasing prevalence of perpetration of violence during COVID. I mean, I think is some data that is actually true, and I think that just makes sense on its face with more psychosocial stressors, distress, adverse childhood experiences that people have. But I do want to, put in a paradoxical plug for the pandemic in that it made us use telehealth. And so the thought of like, so my like social workers who I talked to would say, I could never get my guy to come in to talk about his depression, or if they wanted to expand it to talk about violence because he's working, he's on an assembly line, like he can't take time off. But now he'll just go to his car because like that's his office. And like now I can have a counseling session with him because like, and it makes sense. And it's considered viable by the institution that it doesn't have to be a face-to-face encounter. And I think it just validates that telehealth could work even before the pandemic, but the pandemic just normalizes it, and it makes it that this might actually be preferred by the patient. And like, if my patient is going to talk about a sensitive topic, maybe they'd rather be at home. Like maybe they want to be someplace comfortable. Maybe they don't want to be in a cold exam room where like they don't know half the people that they're encountering and talk to people who they don't know. If it's a family medicine environment, maybe there's a trusted continuity relationship and that's different. Maybe they'd rather be there. But in other environments, maybe he'd rather just be in his car, because that's where he has lots of conversations anyway. And so that I think the pandemic forced us to think about things differently or implement things that we didn't think was previously advisable clinically.
Thank you, Vijay. Elise, so maybe in contrast, the pandemic has forced more activity online. We might see more online scenarios where dating violence could happen. What are you seeing? What are you worried about?
Unfortunately, I haven't seen any data out or any reports out yet that really explicitly talk about electronic dating violence and whether or not it's gone up or not. But what I can say, and kind of just, reemphasize what Vijay said, like there have been quite a few changes relative to the pandemic in terms of going online. And I think one thing that the pandemic really highlighted is how much we do value connection and how much we crave it when we're home all the time. Depending on who we're home with, like maybe we do feel that, maybe we don't. In terms of K through 12 age youth, prior to the pandemic, on average, adolescents are spending 6 hours online. I don't know what the new statistic is, but it's going to be higher. You're doing school online. If parents are working and you can't go out and play, like you might be on, watching TV or playing video games. I think we're just seeing increases in general of the online interactions. What I'd be really curious about, kind of in future iterations, is to see if the increase of interpersonal interactions online helps people understand intuitively that those interactions do matter, and so when we interact in a way that is harsh or violent,